So good evening, everybody, and welcome to the Chest Wall Perforator Flap web series. Today, our topic is going to be on intraoperative indocyanine green angiography and its use in breast reconstruction for flap perfusion, and also how it's used to of fat necrosis. So before we go into today's session, I would just like to acknowledge and thank one of the sponsors for the Chest Wall Perforator Flap web series, the Irilic Group. So they're a group that produces the fluorescence imaging machines, which are affordable and also world-class. Now, what this machine does is it's used to visualize the blood flow, so the perfusion and the lymphatic flow in real-time imaging. And it's safe as we're using near-infrared technology. And it's used for multiple applications. So apart from breast and multiple other specialties as well. So the same machine can be used for flap perfusion, as we mentioned earlier. It's also used in sentinel lymph node mapping, lymphedema management, and several other applications as well in colorectal and GI surgeries. So this was first studied by Dr. Somashekar at Manipal Hospital in Bangalore, and I think they've also published their experience with fluorescence imaging in sentinel lymph node biopsy. There have been several other studies also in its use for perfusion outside of India. So if anybody is interested to reach out to them, this is where their contact details are placed. And thank you once again to fluorescence imaging. So I'll come back to this video at the end with another video. I'd like to introduce our speaker for this evening, who is Dr. Paloma Malaguin Lopez, a plastic and aesthetic surgeon at the Hospital of Germans in Barcelona. So she trained in plastic surgery and then went on to do microsurgery, mostly in breast reconstruction in Barcelona as well. She has very well published, and her landmark publications have been on the use of indocyanine green angiography intraoperatively, particularly in DF flap perfusions, and also in its use to reduce the incidence of fat necrosis. So welcome, Dr. Paloma, and thank you for agreeing to be with us today. I'd also like to introduce our chairperson for this evening, who is the very well-renowned Dr. Arun Kumar Goyal, who is a senior director and surgical oncologist at Max Super Speciality Hospital in Vaishali. So Dr. Arun Kumar Goyal has trained in AIIMS Delhi and has been in the field for over 25 years with more than 75 publications in national and international journals. So welcome, Dr. Arun Kumar. And before I hand over the platform to Dr. Arun Kumar, I'd like to mention a small request that you can put all your questions into the chat box and they will be taken at the end of the session. So over to you, Dr. Arun. Sir, you're muted, so we can't hear you.
Okay.
Yeah.
Thanks, Dr. Kirti and Dr. Nirja. And I must compliment you for the whole concept of the Perforator web series. I have been attending most of these events, and they're really focused on the upcoming field. I would say, at least for India, it's an upcoming field, and it's going into the details. Now coming to the topic of today, that is indocyanine green based angiography. So I think ICG has become something of a necessity for oncology setups with diverse applications. And the speaker today, we have a plastic surgeon from Barcelona, Spain, and she's done and published very interesting original studies about the use of ICG angiography in DF flap reconstruction. One is on the timing of the study, whether it should be done at the donor site or at the recipient site, which one is better. And the other one is what is the impact on fat necrosis over a 1-year follow-up period. So I think right now we'll hand over to our esteemed speaker. And as Dr. Kirti also said, for all audience, please put your questions in the chat box and we'll take them in the discussion session after the talks are over. Dr. Lopez, please.
Thank you very much. Thank you for the introduction, and also thank you to Dr. Gupta for the invitation. I'm very glad to be here in such a fantastic webinar, and I would like to share my experience with the ICG. At the end of my presentation, I'm going to be very happy to answer all your questions. If you want to talk about anything else about the ICG that I haven't talked about it before, for me, it's going to be a pleasure, or if you want to share your experience too. So I'm going to share my screen. Okay, I think I have a problem sharing my screen. Here it says that only the host can share the screen, and I don't know why.
Dr. Ankur, do you need to do that again?
I think you've been made the co-host, Dr. Paloma. Can you try once again? Yeah.
Yeah, we got.
Yeah. Okay. Now, can you see it properly?
Yes.
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 Okay. So if everything is right, here we go. Okay, I know that many of you knows what is the ICG and how to use it, but it is always good to remember the basics of everything. So I'm going to make just a brief introduction about what it is exactly the ICG. As we know, it's a tricarbocyanine water-soluble dye that is presented in a sterile powder in a little pot, and it has many multiple clinical applications in medicine, not only in surgery or plastic surgery, also in ophthalmology, cardiology, neurosurgery, and other specialties. It is demonstrated that it is a very safe and well-tolerated dye, and actually there is no toxic effects described with doses lower than 5 milligrams per kilo. So we can conclude that it's very safe. There are a few limitations that it's important to know about it. We cannot use in patients who has hypersensitivity to the ICG or the iodine, because there is a little amount of iodine in this powder. So we have to take that into account. We cannot use in some thyroid disorders and in premature infants and newborns in whom an exchange transfusion is indicated for the hyperbilirubinemia, because the ICG displaces the biliary salts from the plasmatic proteins. And there are another two limitations that is not clear. I mean, it's not an absolute contraindication, but we have to take care with patients with renal failure and patients who are pregnancy or in a lactation phase. And the rest of the patients we can use very safely. How do we use the ICG? Well, first of all, we have to make a solution of this powder. So in our center, we use sterile water. We put 10 milliliters inside the pot, and we have to mix very well to have a great solution of 2.5 milligrams per milliliter. We can administrate this by two ways: intradermal or subdermal injections. That is very useful to assess the lymphatic vessels, or we can inject endovenous to assess the blood supply, as we are going to see. When we administrate endovenous, there is a selective union of the ICG to plasmatic proteins, and then the dye remains in the intravascular space, so we can assess easily the perfusion of the tissues. After endovenous administration, we use a near-infrared light to excite the dye. So the ICG emits a fluorescence that is captured by this camera. This is an old PDE. Now we have the new one, the PDE Neo 2. It's much better than this one. The quality of the image is much better. And this device transforms the fluorescence that is captured in a grayscale image. There is more or less bright depending on the intensity of the signal capture. That means depending on the quality of the perfusion of the tissue. If the tissue is well perfused, there is very bright, but if it's non-perfused, it's totally dark. Applications of the ICG. Certainly, last years, it's the use of ICG is increasing, especially in surgery. As we have said, we can use in lymphedema for diagnosis and also for surgical planning, especially in the LVA surgeries. We also can assess a vascular system, especially the blood supply assessment of the flaps, as we can see in these pictures. Here in this image, we can see clearly the age of the well-perfused area of the flap. In this case, this is an intercostal pedicle flap, and we can easily remove this dark zone that is non-perfused. There are many papers talking about the skin necrosis prediction of the ICG, and it's clearly established that we can reduce the skin necrosis incidence, especially, this is especially useful in mastectomy surgeries to assess the quality of the skin of the flap, as we can see in those pictures too. Another application is to assess the vasospasm, or at least to confirm or detect it, and to perform a patency test of anastomosis. Here we can see very clearly the vessels of the brain in a neurosurgery paper. And if there is something wrong in the flow, we can see a clear stop inside the vessel. Other application, just to choose the best perforator of free flaps. There are many, some papers talking about that, but I can show you a case in our hospital. It was this one. It's a reconstruction of a breast. We wanted to do a unilateral DF flap, but the patient has a very big scar in the middle of the abdomen because of 2 cesareans performed many years ago, and we needed a flap bigger than the half of the DF flap. So we need half and a little bit more. During the surgery, we found 2 good perforators, one of each side of the DF flap, and we perform an ICG imaging to confirm the perfusion area of both of them. And here is the results. As you can see, the good perfused area of the left side perforator was much smaller than the right perforator. So we can choose this perforator easily. And another 2 more recent applications of the ICG is to confirm venous congestion in a flap, and the monitorization of a flap after the surgery to check that the anastomosis are still okay. And as I said, there are many applications of the ICG. I think that we can talk only about the applications of the ICG, but I don't want to bore you. So I just want you to have the main idea, or that the ICG improves the quality of the surgical procedures because it gives us information about the blood supply, and we can perform a better design of the flaps. Here we have a video of a DF flap, unilateral DF flap. As you can see, it's easy to identify where is the perforator because it's where the dye starts to expand. Here was the perforator, and as you can see, almost the whole flap takes the fluorescence. So it was well perfused. Okay. And with a sterile marker, we can mark the limit of the non-perfused and perfused areas of the DF flap. In this case, it was very clear where it is. And in this picture, we saw that here we have the one limit and here the other one. It was not a common DF flap reconstruction because, as you can see here, we have included lymph nodes because this was a delayed breast reconstruction in a patient who has a lymphedema. So we put these nodes in the axilla with the breast reconstruction with the DF flap. We also check in this patient the recipient vessels. In this case, it was the artery mammary, the internal mammary artery, and the vein. And as you can see in this video, both of them were very great. And after the anastomosis, we also check again the perfusion of the flap. I don't know why, but the quality of this video is not as good as the first one, but all the skin paddle of this flap was well perfused. And finally, on the other side, we perform a reduction mastopexy to make a symmetrization, and we check the perfusion too to show you today. All the breast was well perfused, especially the nipple, that is the critical area, and those kind of surgeries was also great. Well, so as we can read in the literature, the applications of the ICG are many, and it's very useful to assess the flap perfusion and to reduce the skin necrosis incidence. But some years ago, when I started to use the ICG, I had some questions that was not clear, at least to me, reading the papers published so far. So in the first place, we know that we can achieve great outcomes using the autologous reconstruction, like in this case with a free DF flap for reconstruction of the right breast with a very big skin paddle. And we know that we can reduce the skin necrosis using the ICG. But in the DF flap, I think that maybe the skin necrosis is not the main problem that we have, especially in cases like this one, that we don't use any skin paddle. In these cases, it's more important to avoid the fat necrosis. Actually, fat necrosis in the DF flap is it has a really high incidence, as we can see in the literature, is up to 62.5%. And it's also, it has a very important clinical repercussions because there are many more infections, more postoperative time, more need for controls after surgery, more secondary surgeries. All of this increases the cost of the total reconstruction. Fat necrosis also worse aesthetic result of the breast. It could also be a failure or total failure of the reconstruction and need a new free flap. And it causes also psychological problems for patients, especially because the patient feel a hard node in the breast where she had a cancer. And sometimes it is also difficult for the doctor to differentiate this hard node for a metastasis or another new cancer. And we have to order a new test imaging and sometimes biopsy to confirm that it's not a neoplasm. So the question is that we know that ICG is useful to assess the perfusion of flaps, but it is also possible to reduce fat necrosis in the flap. And the second question I asked to myself was, when should we perform the angiography during the surgery, before or after the anastomosis? And I asked me that question because in some papers, some authors, they say that they usually do the ICG imaging in the donor side, I mean in the abdomen, that means before the anastomosis. But some other authors say that it's better to perform after the anastomosis. And no one specifies why do they do that in the papers, or if there is a difference between doing before or doing after the anastomosis. So I wanted to know more about that. For that questions, we performed 2 studies that was published, and we are going to see. The first one is this one that was published in the Aesthetic Surgery Journal, and we included in total 61 patients who has a unilateral DF flap reconstruction for breast oncological mastectomy. And we divided these patients in 2 groups according if we use or not the ICG during this surgery, or the control group without the ICG. We assess the fat necrosis incidence during the first postoperative year and compare both groups. The results. We found a fat necrosis incidence of almost 60% in the control group, but when we use the ICG, this incidence was only 29%. And that means a reduction of more than half. Very important to use the ICG then. And the statistical results were statistically significant. We also wanted to know if we can reduce the size or the grade of the fat necrosis using the ICG. And for that, we use this classification that is published in the PRS journal and is based on a meta-analysis of more than 17,000 DF flaps. And it divides the fat necrosis in 5 grades according to the proportion between the size of the fat necrosis and the total size of the flap and the treatment that we need after the diagnosis of the fat necrosis. If we have to remove and close, if we need, for example, a lipofilling, or if we need another free flap or pedicle flap for good reconstruction. So in our study, we saw that the grade was reduced in all groups from 1 to 5, but the difference was very big in here, in the grade 2. The grade 2, we can remember, is fat necrosis from 5 to 15% of the total size of the flap. And the results here were statistically significant. We also analyzed the need for secondary surgeries because of the fat necrosis. And here again, we saw a reduction of more than half of the total group. And the results of the chi-square test were also statistically significant. Here we have an example of a minor fat necrosis. This patient had here a little node, hard node that was fat necrosis, and she needed secondary surgery because it causes pain in this site. So we can remove the necrosis and directly close. So it was a relatively easy surgery and with a fast recovery for the patient, but she needed a secondary surgery. And there are cases like this one that is more dramatic, the result of caused by the fat necrosis. Here is a big fat necrosis of more than 10 centimeters. That is this zone of here that affects also to the skin. It's like here there is like a scar. So we had to remove all of them and we need a secondary reconstruction procedure. In this case, we put lipofilling, fat transfer to cover the defect of the fat necrosis. And finally, we performed another assessment in this study that was a breast Q to know if the satisfaction of the patients and the quality of life improves with using the ICG during the surgery. And for sure, the satisfaction with breast was much better using the ICG because I think that we improved the fat necrosis incidence, so the patients were more satisfied. Like this is the case. This patient was very happy with the results. Actually, sometimes I don't remember which one is the mastopexy surgery and which one is the DF flap because the symmetry of between the breasts are very good, and she is so happy. And some months later, our results were confirmed with this great study that was written by Ramon Varela et al. That are a great team of plastic surgeons from Madrid, who I have the pleasure to know. So if you want to read this paper, I recommend you because it's very interesting and very well written and confirm our results. So answering the first question, is it possible to reduce fat necrosis using the ICG? As we have said, yes, we can do it. So let's go with the second question. When is more useful to perform the ICG angiography? Before or after the anastomosis? This question is performed just for the flap perfusion assessment, because as we have said, we can use the ICG, for example, to check the patency. So to check the patency, obviously we have to do after the anastomosis, but just to assess the flap perfusion, it's better to do before or after the anastomosis. And here we have this second paper that was published in the journal The Breast. We included 46 patients with unilateral or bilateral DF flap. And in this case, we assess the perfusion of the flap twice in each patient. First in the abdomen, that means before the anastomosis, and after that, after the anastomosis in the recipient side, that was the breast. In this paper, all the anastomosis were performed to the internal mammary artery in a terminal way to have similar results. So here we have pictures of how we do the assessment of the flap perfusion. So as we have seen in the video before, we mark with a sterile marker the limit of the age of the difference of the non-perfused and perfused area of the DF flap, and also mark with a cross where is located the perforator that we use. And we took calibrated pictures, as you can see here. This is a sterile roller. With these pictures, after the surgery, we analyzed the size of this area, the non-perfused area, and the total area of the flap using a very interesting software that it's called ImageJ, that can allows us to measure these areas, irregular areas, I mean. And we can compare between the first measure that was in the donor area and the second measure that was after the anastomosis in the breast in each patient. Here is another case. We have here the perforator location and the non-perfused areas. Another case, our perforator and the non-perfused area of the free flap. So we wanted to assess if there are differences between the two ischemic areas of the DF flaps before and after the anastomosis in each patient. And we measure it including all DF flaps and separately unilateral and bilateral DF flaps. We also wanted to know if there are differences between these areas according to the localization of the perforator in the horizontal and vertical line, and also with some risk factors that was those of the nulliparity of these patients, smokers, radiotherapy, diabetes, hypertension, hyperlipidemia. I mean, we wanted to know if you have some of these risk factors, or depending on the localization of the perforator, if there are changes in the perfusion of the flap before and after the anastomosis. Our results. In all cases, the correctly perfused area was the same or bigger in the recipient side. That means that the well-perfused area of the flap was never bigger before the anastomosis. This is the most important finding in our study, and the results were statistically significant. What did we do with this information given by the ICG? Well, with the non-perfused areas, that means this dark area, in all cases, we remove it without thinking, let's say. We remove in all cases the dark area. But the areas that were well perfused according to the ICG imaging, we realized that it was not necessary to include all the well-perfused area in the most of unilateral DF flaps, but we had to include all the area in bilateral DF flaps. Here is an example of why we don't need all well-perfused area in unilateral DF flaps, because sometimes we have a huge DF flap, as we can see in this patient that was obese, and in that one, who has a very little breast in the contralateral side. So obviously we don't need all this flap to create the new breast. We can remove also some parts of the well-perfused area of the DF flap to make the size that we desire. And more results. We wanted to compare unilateral versus bilateral DF flaps. So we saw that the perfusion improved in almost 25% of unilateral DF flaps. That means that after the anastomosis, the perfusion improves in these cases. But in the bilateral DF flaps, always was the same area before and after the anastomosis. And that means that there is less probability to improve the perfusion in bilateral DF flaps after the anastomosis. And the results were statistically significant. Regarding the localization of the perforator, we saw that lateral perforator has less probability to improve the perfusion, but we don't see any difference between the localization in the vertical line. And the risk factors, only the tobacco was statistically significant to have less probability to improve the perfusion after the anastomosis. So, answering the question, when it's more useful to perform the ICG? For me, it was clear that it was in the donor side, in abdomen. That means before the anastomosis, if we want to design the flap with the information given by the ICG. There are some advantages in performing the ICG in the donor side. We can design the flap with greater precision because we know the original perforation of the DF flap, and we can do a better planning of the adaptation of to the recipient side because we know before how it's going to be the size and the contour of the flap. It's also good to perform before the anastomosis because we can assess the quality of the original flap perfusion, that means before the anastomosis. And this is especially useful in some patients who has, for example, scars or who has a liposuction, because sometimes the ICG imaging, it's a little weird if there is a previous surgery. So it's better to know before the anastomosis, because if we realize that there is a strange image after the anastomosis, we can think that there is a problem with the anastomosis, and it's not, it's just the scar of the flap. And another advantage is that we can choose the best perforator. We can check the perfusion of different perforators in the same patient and choose the best one of them, as we can see in the pictures that I showed you before. So the conclusions. The ICG is a useful tool to evaluate and optimize the flap perfusion intraoperatively and in a dynamic way. And it improves the final outcomes of reconstructive surgeries. Actually, the ICG reduces the fat necrosis incidence of the DF flap, as we can see. In addition, reduces the degree of fat necrosis, reduces the need for secondary surgeries, and improves the satisfaction and quality of life of patients. Its use is very simple and safe. The best moment to perform the ICG, if we want to assess the perfusion of a flap, is before the anastomosis, and if we want to repeat after the anastomosis, it's okay, we can perform it, but it's better to know how is the flap before the anastomosis too. With that, we can know the perfusion of the flap given by the original perforator in the donor side. And this is very important if we want to know the original perforation of the ICG. Bilateral DF flaps, lateral perforators, and tobacco use have a statistical significant association to less probability to improve the perfusion after the anastomosis. And that's all. Thank you very much. This is the staff of plastic surgery in our center. We want to invite you all to come here to visit us or to share your experience with us. Here I give you my email if you want to resolve some doubts after this webinar, or if you want the original papers. you can write me, and I will be very happy to answer you. So thank you very much, all of you, for your attention.
Dr. Nirja, can I start?
Yes, please go ahead, sir.
Yeah.
Please take over. Yeah.
Firstly, thanks, Dr. Lopez, for those wonderful talks about both the works that you have done. So basically, the discussion today is going to be about assessing flap perfusion. Okay. So I think for the interest of all the audience here, I would like you to comment about the application of ICG beyond DF to other free flaps and to pedicle flaps, perforator flaps, and also what is your experience with using ICG in assessing perfusion in diverse settings in breast surgery? Dr. Lopez? Dr. Lopez, you could
Yes.
hear me?
Yes, now I can hear you, sorry.
Okay, so I'll repeat.
My speaker, and I cannot hear you very well.
Okay, so I'll repeat it. So
Yes, please.
you've described ICG angiography in DF flap reconstructions, but what is your experience with using ICG in other free flaps for breast reconstruction and for pedicle flaps, including perforator flaps? So have you used it in other applications for breast surgery?
Okay, okay, yeah. Good question, because actually we use the ICG almost for all reconstructive surgeries, because it gives us a very valuable information about the perfusion. So we also use in, for example, ALT flaps and skip flaps, and also pedicle flaps. I'm not sure if you remember the talk of Dr. Cristian Carrasco about the ICAP flap. So in this case, this is a pedicle flap, and we usually use the ICG to check the perfusion, especially in the edges of the flap, because I think that we can design a much better flap with and optimize the perfusion and reduce the fat necrosis and skin necrosis incidence of these flaps. So for me, in my opinion, we can use in all kind of flaps. We only have to take care with patients with, for example, hypersensitivity to iodine, as we have said before,
okay,
contraindicated, but in all other patients, we use that.
Okay. So I was seeing the dose of ICG that you have described in your publication says 1 ml of ICG. Is that true?
Sorry?
The dose of ICG, you have used only 1 ml of solution? 1 milliliter of ICG solution?
Yes, we usually inject 2.5 milligrams, because the solution is 2.5 milligrams per milliliter. So we use 1 milliliter of this solution. When we want to assess the lymphatic vessels, we use another different solution. But for assessing the perfusion of the flaps, I mean endovenous, it's 1 milliliter of this solution. Yes, it's enough, but it is safe to use the whole pot. I mean the whole 25 milligrams that is in a pot. So you can repeat the imaging if you want, or you can use more if you want to see clearly. So there is no problem with those. but it's enough with one.
But I have seen a variation, like the paper that you mentioned by Dr. Varela et al. From Madrid. They have used 2.5 ml of the solution, and there are other publications which use a dose based per kilogram, and the total dose then comes much higher. So my question is, would a dose of ICG make a difference to the assessment of perfusion?
Yeah, I know that in the case of Ramon Varela team, they use another different dose. I think that the important thing, it's more important to have lower light than the dose that you use. I mean, there is not much difference between using 1 milliliter to 3 milliliters of the ICG, but if there is a light in the room, the image changes a lot. So for me, it's much more important to have a proper light than the dose, but it's correct to use 3 milliliters of this solution too. Yeah, sure. And it depends sure of the weight of the patient. But I don't find very significant differences in the dose, more in the light.
So in terms of timing, definitely you put forward your position that you would always like to use it before division of the source vessels. Then, so you recommend that a selective use be done after the anastomosis has been carried out? Is that what you wanted to say?
Yeah, for me, it's very important to perform the ICG imaging before the anastomosis, but sometimes we can repeat the imaging after the anastomosis. For example, if you have some doubts about the quality of the internal mammary artery or the patency of your anastomosis, it's going to be useful to repeat the ICG after that. But in our study, we saw no case where the perfusion was lower after the anastomosis. In all cases, was the same perfusion or even better after the anastomosis. So there is no problem in repeat, or if, for example, you want to check a venous congestion or the patency, obviously, in both cases, you have to do after the anastomosis. But if you want to design with very precision design the flap, it's much better to do that before the anastomosis.
Like in your study, also 2 cases had a change in flap design after the assessment was done at the recipient side. That is nearly 4.3% of your population.
Yes.
So wouldn't then it be better to do it at both times? Because even a 1% change in flap design is significant. Would you say that?
Yeah, well, in the paper, we saw that in 2 cases, we could put more area, we include more area in the final design of the flap. That means in some unilateral flaps, we have only, for example, this size of the flap was well perfused before the anastomosis, but we needed a bigger flap. So after the anastomosis, we check again the perfusion and was a little bigger. So we could include this new part in the final design. So this is another another indication to repeat the image after the anastomosis. If you need more area, it's probably that after the anastomosis you can include more volume. But if you don't need more volume, that is the majority of cases, at least unilateral DF flaps, it's better to do before.
Okay. So there was a question from our audience about how to differentiate between venous and arterial issues in a flap. Say once, so if you have say you're doing a study after the anastomosis, so how do you judge if there is a venous problem or an arterial problem? So how is the pattern of ICG perfusion different? Or how do you assess venous versus arterial?
You mean how we differentiate the venous and arterial?
Yes.
Yes, because this is a dynamic imaging. So we are holding the camera and we inject the dye. So we first see the dye inside the artery and crossing the anastomosis. So if there is no problem in the perfusion of the flap, there is no problem with the artery. And after that, a few seconds after, we see the venous. So this is one of the advantages of using the ICG, that is a dynamic imaging. So we can differentiate easily that.
So if there is a problem in venous drainage, then you can do an additional venous anastomosis, and that can help in salvaging the flap?
Yes, actually, sometimes in all the flaps, we dissect the CA, the superficial artery of the contralateral side, and just in case we need a secondary vein. So after performing the ICG, if we see the dye in that vein in a high quantity, we also perform a secondary vein. Yeah, and we usually do to the cephalic vein, the supplementary anastomosis.
So now my question is about this interpretation of the perfusion, the black, white, and the gray in between. Like, do you have a very clear-cut demarcation between a well-perfused and a under-perfused area, or there are some areas which are somewhere in between where you're not sure what will happen?
Yeah, that's a good question, because sometimes the limit between the non-perfused and perfused area is not black and white, as we have seen in the video. Sometimes it's gray, and sometimes you have some doubts about this, some area of the flap. The thing is that, as I have said, that is a dynamic image. So you are going to see the first area of the flap with the fluorescence is the better area, the best area. So we are sure of that. And after that, there's like a gray zone that we know that is perfused, but it's not great perfusion. So if we don't need a big flap, we also remove this area. But it's true that sometimes it's a little subjective, and it depends on the experience of the surgeon. Sometimes it's not very clear. And in those cases, if the surgeon doesn't have enough experience with the ICG, in those cases, it's much better to use a scale, a color scale, to compare zones. Or sometimes there is a software included in the device, like, for example, SPY, that is not a grayscale image, it's a colorful image. In those cases, it's much easier to take a decision with this software. But if you have experience with the ICG, I think there's no problem with that.
Okay. Is there any difference in the speed of filling, like something happening very fast versus happening a little slower? Is there any difference in different cases? Have you noticed anything like that?
Yeah, that's true. Sometimes you see the dye expanding in the whole flap very fast, and sometimes it's very, very slow. And this is why it's very important to have a good anesthesiology in the room, because the tension, the tension of the patient, the arterial tension, is very important, and also to keep the patient warm. If the skin is very cold, the choke vessels are closed, and the dye moves very slower. So yes, it's important to have a good control of the hemodynamics of the patient.
So in your study, you have been using CT scan also prior to surgery. So if you're going to use ICG, can you do away with CT scan?
Yes, we usually perform the CT scan in all DF flaps, especially useful if we have to perform a bilateral DF flap. But in my opinion, it's much better to choose the perforator with your clinical experience, for sure, and with the ICG imaging more than CT scan. The CT scan gives us important information, but about the way of the perforator, because we know that sometimes there is a very long way inside the muscle. So we have to be prepared that we are going to be have a difficult dissection. But the CT scan doesn't give us information about the perfusion or the quality of that perforator, only the anatomical landmarks of the surgery. So it's important, and we usually perform the CT scan, but if we have doubts about which perforator we chose, for me, it's much better to use the ICG imaging, because if the way in intramuscular way is too long, for us it's no problem. We know that we are going to need more time, more surgical time, but if the perfusion is going to be better, why don't do that?
No, but would you be comfortable going to the OT without a CT scan if you are going to do ICG? Would you accept that?
Sorry?
Would you go to the OT without having a prior CT scan if you are going to use ICG? That is the question I just wanted to ask.
Yeah, I think that maybe the ICG could be a better choice than the CT scan.
Yes. Okay. The paper by Varela and all, they have not used a CT scan. That is what they said. All the cases they did were without a CT scan. So that is why I brought up this question.
Yeah.
Okay, now another thing is that the fat necrosis rate in your study was still around 20% plus. While the study by Varela et al., it has come down to 8% with the use of ICG. Is there anything which can explain this difference?
Yeah, I think that 30% sounds a lot of fat necrosis, and it really is. But the difference between both studies is that in our study, we perform an imaging test in all patients. Okay. So sometimes you can, especially in big flaps, you cannot touch a little fat necrosis in the middle of the flap, but you can see it with an echography, that's on the study.
Okay.
Yeah, and also because I think it's because of the risk factors, because in our study, most of the patients are obese. So the size of our flaps are really big, and the patients that we included in the study has at least more than 50% has at least 3 risk factors for fat necrosis. That is really high. Yeah, I think that maybe for these 2 reasons, we have still high rates of fat necrosis.
Okay. So in your study, how many of the reconstructions were primary and how many were secondary?
How many what?
Primary reconstruction and secondary delayed reconstruction.
I'm sorry, I don't remember the percentage, but I think that it was specified in the paper, so I could check after. But we have more immediate breast reconstruction and delay, much more.
And after you have checked the perfusion with ICG, if you are sacrificing the overlying skin, does it affect the fat perfusion? Because we sacrifice a fair amount of skin based on the recipient area while the fat is retained.
Yeah, we check the perfusion of the flap, but also the skin of the recipient side. Yeah. So in the same imaging, we can check everything to have less skin necrosis incidence after that.
So would you like to say that every case of breast reconstructive procedures today should have ICG angiography as a routine?
Yes, for sure. Yeah, we in our center, we use the ICG in all kind of breast reconstruction. For me, it's especially useful when we are going to reconstruct the breast using an implant. It's not only for flap perfusion, but also for the perfusion of the flap of mastectomies, because as we know, sometimes the breasts are very big and the flaps of the mastectomy are very thin. And sometimes we have surprises making the ICG and some area that could be well clinically, sometimes are dark in the ICG. So we have to remove this skin area. So yes, it's very, very useful to perform an ICG angiography in all kind of breast reconstructions.
Okay. So has any cost benefit analysis been done about use of ICG? Are you aware of any such study?
Any cost benefit?
Yeah.
I've never done that, but there are 2 papers at least that have said that it is really cost effective. I think that it depends on first on the country, because the price of the ICG, it was a surprise for me, but the price is really, really different between one country or another. Here in Spain, one pot is about 80 euros, like a little less of $100. But for example, in Japan, it's only 4 euros, $4.
Okay.
And in some Latin, for example, in Chile, I think it's like $200. So I think it depends a lot on the country. And it also depends if you already have the device to analyze the imaging. I mean, if in our center we do lymphatic surgeries, so we need the device for the diagnosis and treatment of lymphedema. So we don't have to spend the money in the device because we have already that for another pathology.
Okay.
So I think it depends. But if you have the device and it's not very expensive, the chip in the pot in your country, I think it's totally cost benefit.
Okay. And have you had any situation, I think this is the last from my side, where the test has created a confusion in your decision-making process or confounded? Have you ever had any such situation? No.
Yes, I think we have had every kind of situations with the ICG, because sometimes there is not a clinical correlation between what we see in the ICG imaging and clinically. So the decision is always for the surgeon. So I think that the experience of the clinical experience of surgeon is more important than the imaging, but the imaging is an extra information that we have to take into account. And sometimes the ICG has is right and the surgeon is not.
So Dr. Nirja, Dr. Kirti, are there any other questions, or I couldn't see any other audience questions? There are some questions about camera specification, but I think that may be more to do with the equipment vendor and all rather than with Dr. Paloma.
So I think most of the questions have already been answered, and that was a very interactive kind of a discussion. Dr. Goel has put up all the relevant questions which strike our minds. One of the things which I think Dr. Ramani wanted to ask about turbocharging. Has this been covered up? If ICG shows non-perfusion of an area of the flap, can the whole flap be used if an additional anastomosis is done? A turbocharging.
This was discussed. Basically, it is a venous anastomosis which is used for turbocharging, and that was addressed. Yeah.
So I think we can wind up here. We had a very good interactive session, and I'm sure everybody has enjoyed this also. Dr. Kirti, over to you, please. Can you please share your screen to show those videos from Ireland?
Yeah, sure. Yeah. So there are 2 videos that we have from our sponsors on ICG in perfusion for margins and in the ALT flap perfusion. So I'm just going to play these videos for the audience. It's just a few seconds over here, so you can. Yeah, so you can see the dye lighting up over there, slowly going into the flap area. And that's how the end result of it looks as it keeps going further. See it lighting up all through the end. So this is mainly to look at the margin assessment and just to see how the vascularity is right up to the edge of the flap. And I'm going to show you the next video shared by Irelek with us, which is done on an anterolateral thigh flap actually for perfusion. So I'm just going to start playing this. And here again, you can see the main vessel and you can see the flow coming into the flap slowly. So you can see that whole area lighting up as well. So you can see how it comes out from the main artery, branches out into the flap area. Yeah. So I'd like to thank Irelek again for sharing these videos with us to share on this platform today. And I think if we have no more questions, we'll call it a day, Dr. Nirja.
Yeah, sure. So we have got very enthusiastic audience and a lot of questions on Sentinel plus flap being harvested and ICG being used in the same situation. But since Dr. Paloma belongs to a plastic surgery field, I think we'll offer these questions to our next speakers, maybe Dr. Somshekhar or Dr. Kopikar. And we wind up today and we'll meet you all next Saturday, same time, 8 o'clock.
Yeah. Thank you, Dr. Paloma, and thank you, Dr. Arun.
Thank you, Dr. Kethi, Dr.
Thank you all.
Nirja, Dr. Paloma.
Yeah, thank you all. I have enjoyed a lot today. So I hope to see you soon, and especially next Saturday here in the webinar, and keep safe.
Thank you.
Thank you so much. Take care.
See you. Bye.